I'm Daniel Levine, and this is the Bio Report.
Brain tumors are difficult to treat in part because of the blood-brain barrier, the need to protect healthy and sensitive tissue surrounding tumors, and the limits of existing therapies. While there have been great advances in other types of cancer, there's been relatively little progress in treating these CNS tumors. Plus Therapeutics is developing targeted radiotherapies that provide high doses of radiation directly into the tumor with a catheter. The approach enables the delivery of higher doses of radiation while minimizing exposure to healthy brain cells. We spoke to Marc Hedrick, President and CEO of Plus Therapeutics, about the challenges of treating brain tumors, the limitations of current therapies, and why the company's targeted radiotherapies have the potential to create better outcomes for patients. Marc, thanks for joining us.
Hi, Danny. Yeah, thanks for inviting me.
We're going to talk about central nervous system cancer, Plus Therapeutics, and its efforts to develop targeted radiotherapies to treat these conditions. Well, let's start with the group of cancers you're focused on. What do they include?
You know, it's an ever-expanding list, and we started clinically with our lead drug in glioblastoma, and it actually is the most common primary brain cancer, but it's rare. So it's only about 15,000 patients per year in the US. And so then we've moved into pediatric brain cancer, which in fact is a bit rarer. Um, and then most recently, we've completed a phase 1 trial for leptomeningeal cancer, which probably isn't something that is commonly talked about, but there's an epidemic of it in the U.S., quite frankly. And so we're cutting across a number of the different types of cancer, both metastatic and primary. And then I think, downstream, some of our core technology can be used outside the brain and spinal cord. But right now, that's where our focus is. And just to finish up the answer to this question, because I think it's highly relevant as to why we're doing what we're doing. Cancer survivals in most kinds of cancers have improved. In some cases, they're almost like chronic diseases. Not so with brain cancer. They're pretty flat. For example, glioblastoma hasn't had an approved drug in over a decade, and the one that was approved does not improve survival. So it is kind of the unmet need of unmet medical needs in oncology. And it really, our view is it's going to take a kind of complete change in approach to make a material impact to survival.
And how are these cancers typically treated?
It really depends on the cancer type and location, but generally speaking, it's a mix of three things. It's kind of the typical three that are used in most other cancers. It's chemo, radiation, and surgery. Uh, the With some sort of mix of those. Of those three, I'd say generally speaking, radiation gives you the best incremental improvement in survival over surgery and chemo. And there are two big reasons for that, particularly as it relates to the brain tissue itself. And that is cancers, once they're in the brain tissue, tend to expand within the brain. They don't metastasize outside of the brain. And glioblastoma specifically, it's like an octopus. It has the body and the tentacles, and it is very difficult to eradicate the tumor with surgery when you have to consider these tentacles that are coming out. Oftentimes, you can't see them on imaging. And then with chemo, there's a huge problem that called the blood-brain barrier. That the same cellular and molecular uh, 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 fence that is used to keep bad stuff out of the brain also keeps chemotherapy out of the brains. Only about 2% of drugs get into the brain tissue itself. And so that's those are two high level important reasons why surgery and chemo aren't great solutions, and why on a relative basis radiation is better, because heretofore, I mean, I'm talking about going back maybe 100 years or so, when external beam radiation was initially introduced into clinical practice. You fire a beam through the skull and into the, the tissue, and so you get around the blood-brain barrier in a way, and it treats the entirety of the tumor, not that's sort of limited by surgery. So if you look at incremental survivals in these three different things, you get a much more bang for your buck, if you will, from a survival perspective with external beam radiation.
How effectively are we able to treat these cancers, and how big an unmet need do they represent?
Again, it is sort of cancer specific. So glioblastomas are kind of the worst of the worst of the primary brain cancers. I mentioned kind of the number of patients in the U.S. that have it a minute ago, and it's quite rare, but it's so devastating that uh, most people that I talk to either know somebody that's had it or have a friend of a friend. I mean, you can't hide it when you have these tumors, and patients die relatively quickly. So patients with glioblastoma die, and they have a median overall survival after their initial diagnosis of maybe 14 or 15 months. It almost always recurs after treatment, and then those patients die in about 8 months. And that's pretty rock solid data across a big, group of patients. That's really the hurdle rate clinically to develop therapies. Um, so, but there are types of glioma, kind of same cell type as glioblastoma, but less aggressive, and those can actually be cured, and those survivals are much longer. So the degree of the severity of the cancer type is important, even as it relates to glioblastoma. For metastatic brain cancers, which is really where the big numbers of patients are, and we're talking about maybe 1 million patients in the U.S. a year that are at risk for metastatic brain cancer. Uh, there uh, their types the types of cancers that metastasize to the brain are really all over the map. It's breast cancer and lung cancer are two of the top ones, but melanoma, gastrointestinal cancers, prostate cancer, hematologic cancers. So a variety of different kinds of cancers can find their way into the brain, and then once they're there, you really the therapeutic options are very limited, and the outcomes are poor.
I suspect there are challenges not only about delivering these therapies to the brain, but developing medicines that can effectively kill cancer without damaging healthy brain tissue. How big a challenge does that represent?
Well, there's a little bit of a paradox in that you're right. It's hard to get stuff into the brain reliably and in high enough doses to get meaningful impact, whether it's radiation or drugs. It doesn't so much matter. However, the brain's an interesting organ because it's not as metabolically active as other organs in the body. For example, the skin, the gastrointestinal tract, the uh, the blood, hematologic system, uh, and a variety of other organs are liver is very metabolically active. There's a lot of cellular turnover in the brain. There's not a lot of new cells being made. It's just called mitosis. And so once you get radiation or a drug there, um, it tends to spare the normal brain and kill the tumor cells disproportionately. So there's an aspect to the nature of the brain tissue that's it's sort of favorable, but this delivery issue is a big problem, and uh, the invasiveness within the brain is an equally big problem. And so that the the thinking around what might work uh, is based on kind of previous decades-long paradigms are just suboptimal, and that's why the overall survival rate hasn't really changed.
We spend a lot of time on this show talking about cutting edge cancer therapies such as immunotherapies and cell therapies and antibody drug conjugates. Oh, we spend less time talking about radiotherapies, but they continue to be cornerstone treatments for cancer in general. How good are they, and what are their limitations?
For radiotherapy, generally speaking, or
Yeah.
let me compare and contrast a bit. So, uh, first of all, generally speaking, I think about 30% of all patients with cancer get some kind of radiation. So that gives you an idea of just how material that is to the overall therapeutic approach to patients with cancer. In the brain specifically, it I would say it's much higher because surgery is not great. It's rare to get a complete resection, and chemotherapy can't get through the blood-brain barrier. You become very reliant on radiation, and so that's commonly given. That's external beam radiation. So that's standard of care, and that's been out there for decades. And you see some sort of incremental improvements, but if your listeners are aware of the technology development life cycle you see across tech, you're very much in a mature market as it relates to external beam radiation. The improvements now aren't step functions; they're small incremental improvements, and so that's kind of where we come in. And uh, the team that developed our approach, uh, both academically and corporately, have take taken this idea that okay, radiation works. It works very well. It's incrementally the best killer of brain cancer that's out there, but the delivery's the problem, and the drug construct is an equally formidable problem. So for glioblastoma, for example, we have a drug that delivers, perhaps up to 20 times the amount of radiation that you can get with external beam radiation, sort of traditional radiation. And it solves a key problem with external beam radiation, which is the dose limitation. If you really crank up the radiation from an external beam, you've got to the beam has to pass through normal tissues, and then if you get and just to put it in perspective, the units aren't necessarily important, but the relative numbers are. So radiation that's absorbed by the brain is measured in something called gray, and external beam radiation in the recurrent glioblastoma setting, and everybody recurs, is about 30 gray. We're delivering up to 740 gray with our approach. So it really is, it is a step function improvement uh, in terms of radiation delivery. And the the drug we use is actually a drug that's made in a nuclear reactor. It's a it, it's rhenium-186 is the radioisotope. Has a you know it's I would say it's easy to relatively easy to make. It's a the starter compound is very common. Um, it does take, it is a complex drug in its formulation. There are three key parts, but at the end of the day, uh, it's a, it's a radioisotope that's bound in a lipid uh, membrane, and then it's essentially fracked into the brain. And I'm kind of referring to fracking in oil and gas, where break up shale deposits to release the gas, where that and the water is pushed under pressure to break that up, we push the drug in under pressure. And once we turn the pressure head off, the drug stops moving and it stays where it is. And the entirety of the irradiation load is delivered only to where you intend to put it. And so we bypass the blood-brain barrier by going directly to the tumor. And then we use a compound that is not easily absorbed by the body. And by the time it's absorbed, all the radiation has been dispersed to the tumor where you need it. That, typically 10 to 20 times the amount of radiation. So it's a novel drug construct, and it's a novel delivery approach. And the delivery approach, I mentioned fracking, and I just use that to kind of create a word picture of what we're doing. But it um, it's actually a very kind of ready for prime time technology. This was developed by, I think, at the NIH 30 plus years ago, convection enhanced delivery. Um, and uh, it's built off the backbone of standard brain biopsy technology. So anybody that has a neurologic issue, gets an MRI, and they see a tumor in the brain, they go for biopsy to see what it is. Makes total sense. And to do that, you've got to put the biopsy catheter very precisely into the tumor, because you don't want to biopsy normal brain, then you'll think it's not a problem. So you want to make sure you get the region of interest that you suspect is tumor. And so geospatially, it's a very refined approach. You can get within 1 millimeter of your target using computerized software planning that's registered in 3D, so you know exactly where the tumor is in space, how deep it is relative to the brain. And then, so use that case planning software that drives the neuronavigational equipment that are in, essentially every, hospital that does neurosurgery in the country. But rather than biopsy, put the needle in, take a piece of tissue, remove it, and then let the pathologist figure out what's there. We actually leave up to 5 catheters behind, and that the number of catheters, the depth of the catheters, and the geospatial orientation of those are all planned out in silico on a computer before the procedure. So the biopsy's done, it's cancer, you leave the catheters in, patient, spends overnight in the hospital, and then the drug is delivered uh, as kind of how I mentioned before, and then the patient goes home, and that's the procedure. And so compare that procedurally to external beam, where to give 30 gray, that's 4 to 6 weeks of treatment where you're going in to the radiation oncology clinic and receiving, maybe 1 gray over 30 different doses. So patients actually prefer going in overnight in the hospital. It's a pretty simple procedure as neurosurgical procedures go. They get the drug, they go home, and that's it. So I think that hopefully kind of paints the the difference in the external beam approach of radiation versus ours. They're both radiation. They're kind of different kinds of radiation in a way, and I'm happy to discuss that more, but it's really a fundamentally different way of delivering radiation that's been out there for decades.
And the drug you're describing is your lead experimental therapy, Rayobic.
It's Rayobic, that's right.
What's known about how long you're able to maintain exposure to rhenium-186, and how do the treatment and nanoliposomes clear from the brain?
Yeah, so the drugs that the reason for the formulation is to try to match the uptake and processing of the drug substance, so the body's mechanisms of removing the drug, with the half-life and the physics of the radioisotope. And so it just so happens that rhenium 186, it's the 186 isotope of rhenium, has ideal physical properties for neurologic cancers. And what do I mean by that? So when you talk about a radioisotope, you talk about the essential element, uh, the number of electrons, the atomic number, and so forth. The path length, how far does the radiation travel once it's, in its final resting place? How much energy does it deliver? And what's its half-life or duration, amongst other properties. And so rhenium is ideally suited for the brain because it's got great chemistry for uh, drug manufacture. Its half-life is about 90 hours, which means it's there for 2 or 3 weeks in a meaningful way. Its path length is 2 to 4 millimeters, so you don't send high doses of radiation throughout the brain. You really limit the exposure to just the area that you planned on your preoperative case plan that dictated, what do you need to deliver and where to get to get an impact to survival. So the physics match the formulation, and um, the brain has cells that will chew up lipid membranes. They're sort of like macrophages, but they're kind of the glial cells do the cleanup after a stroke uh, or surgery or some other injury to the brain. So it's that same cleanup mechanism that's used to clean up the drug. But the key thing is, as part of that cleanup process, you're cleaning up the decayed rhenium. It's no longer radioisotope, so it's cold, in other words. So the formulation itself keeps it there until the radiation gets fully absorbed, and then it triggers um, uh, the processing of the drug construct, after that. So that's kind of how it all works together with the radioisotope and the formulation.
And what's known about Rayobic's safety and efficacy from the studies you've done to date?
Well, we will be presenting our phase 1 data at the end of next week at the Society for Neuro-Oncology, uh, American Society for Clinical Oncology combined meeting in Baltimore. Um, so that's non-public information, but I can guide you sort of generally based on interim data that's been published. First of all, we in our phase 1 trial, which is a dose escalation trial, so we start off at what we think are very low doses, and then we escalate that dose in a specific sequence with the goal of trying to get to the maximum tolerated dose, like testing to failure, if you will, is kind of generally how this works. And so we tested all the way up through 6 different dosing cohorts, and we failed to reach a maximum tolerated dose. In other words, we didn't hit the stopping rules. However, what we observed is that it looked like the drug has an efficacy signal at the first cohort. So we felt through that whole process of phase 1, we felt like that even the initial low dose actually showed a response, and indeed it did, and we'll detail that next week. But then we we looked at whether there's systemic toxicity, that bone marrow toxicity, sort of common with chemotherapy and targeted radiotherapeutics, and that was limited. Um, and so the safety profile and the clinical benefit rate was very promising. Furthermore, and we can talk about this if you think it's interesting, Danny, but Plus recently acquired a diagnostic uh, technology that's the only technology out there that quantitates the number of tumor cells in the fluid around the brain. And so we can, um, it's a way to measure down to 1 cell per milliliter of fluid from around the brain, highly sensitive tests. And it also showed a pretty substantial improvement after a single dose in the number of tumor cells in the cerebrospinal fluid. And this is for a type of metastatic cancer called leptomeningeal cancer.
Would that be used as any kind of a companion diagnostic?
No, I mean, the diagnostic could be, but it's much much broader than a companion diagnostic. In fact, I mentioned earlier, there's 1 million uh, people in the US that are at risk for leptomeningeal cancer, and that's cancer of the fluid space around the brain. And I mentioned the different cancers that cause it, like breast and lung and so forth. So theoretically, that entire group of patients is potentially a candidate, in the appropriate clinical circumstances for our diagnostic technology, which is called See Inside. Like you're seeing inside of something, but it's spelled CNS IDE. And so it's not limited as a companion diagnostic. It's a general diagnostic platform that looks not only at tumor cells, but a much broader scope of changes in the fluid around the brain that helps the doctors to guide and tailor therapy.
Is there some plan to market that diagnostic?
Yes, we are launching that this month. Um, and we just put a press release out recently. Um, it, kind of stay tuned. But by the second half of the year, we'll be making that available first in Texas, uh, in our home state, and then over the next year, throughout the lower 48.
And is this something that's already FDA approved? Is this a CLIA lab model?
Yeah, it's a laboratory developed test. It's a CLIA lab model. We have a registered CLIA lab that's in Houston. So the specimens are taken at the hospital, and then they're shipped to our centralized facility where the testing's done, and then we report that data back to the doctor.
And what's the development path forward for Rayobic?
Yeah, so as I mentioned earlier, there's 3 clinical indications that are currently under development for Rayobic. One of which is glioblastoma that's in phase 2. The phase 1 data was recently published in one of the Nature journals, Nature Communications. And so that's available publicly. It's a scientific publication. And the phase 2 is enrolling. We've got a few patients that are left to complete that trial, and we'll likely provide an update. I doubt it'll be finished by November, but we'll likely provide an update at the Society for Neuro-Oncology annual meeting in November. That's glioblastoma. Leptomeningeal cancer, as I mentioned, has completed the phase 1. That data will be presented uh, next week. And the called phase 1b/2a is currently enrolling, and that's a dose optimization trial. So the phase 1 was to find, what's the ideal single dose, and then the dose optimization trial is really geared to finding out how many doses are ideal. And we think that based on the phase 1 data, we've got a number of patients that have lived years with the disease. And this is a disease that kills patients in 4 to 6 weeks without treatment and 4 to 6 months with treatment, yet there's nothing approved for it. So doctors sort of employ a kitchen sink approach to these patients with leptomeningeal cancer. So we're seeing survival rates that on average are well beyond those that are reported in our phase 1, which is quite unusual, but also seeing some very long tail survivors on patients that have received multiple doses. So we think that a multiple dose approach is going to be the way to go. And so we're just trying to nail down the dosing regime. And then the plan will be to talk to the FDA here in the near term and kind of determine what the path to approval might be for that indication. And then the final one is pediatric brain cancer. It's a much longer path with the FDA to treat kids with cancer, and the scrutiny level is very high. We just got through that, and we'll be starting that trial, I hope this year, at our lead institution, which is Northwestern University and the Lurie Children's Hospital in Chicago.
My sense is that this therapy could be used elsewhere in the body. How broadly applicable might it be, and how are you thinking about other potential indications?
So you're right, and we I don't think right now this particular drug with this particular radioisotope would be optimal for systemic delivery. It's there are other approaches that might be better, but when the central nervous system, you've got anything you put in the systemic circulation, in other words, through a vein, you've got to get through the blood-brain barrier, and as I mentioned, very small number of patients actually will cross that. So that's not even really in the cards. But this drug could be useful in potentially in pancreatic cancer, liver cancer, um, and certain types of lung and ovarian cancer that where we do have some data showing that it is potentially useful. So I think those sort of indications are in the boiler room being developed, but are not yet in the clinic.
How much funding have you raised to date, and how far will existing funds take you?
So the company the company goes back a ways. The company had a prior technology that we divested, so it kind of limited to the more recent time frame. And company has cash to get through the end of next year, and opportunities to raise additional capital at a minimal cost of capital. The company's actually it's been an interesting 3 or 4 years with the company because about half our burn has been offset with grants. So we have $25 million in active grant support from a mix of the National Cancer Institute here in the US, the US Department of Defense, and the state of Texas. So it's really we've been able to substantially reduce uh, our dilution or our burn because it's been materially offset by grant funding. So I think in that time frame, we've been spending about 12 to $15 million a year, but it's sort of steadily increasing as we get to a pivotal trial, which we think is potentially as soon as next year. That burn will go up, but that will also be impacted by our diagnostic, which we're launching. And we think diagnostically, the diagnostic market's about $100 billion global market. There's a $6 billion hole in the diagnostic market around the brain and the cerebral spinal fluid. And we think we have the best option to fill that hole. It's a substantial unmet medical need that we're in a prime position to fill. So we think there's some interesting opportunities for the company to offset our therapeutic development work with our diagnostic.
And when you talk to investors who are often focused on the latest and greatest, is despite the novelty of what you're doing, is there hard to get their attention around a radiotherapy? And are you talking to different types of investors because you have this diagnostic play?
The answer is no. It is not. It's not been hard to get attention from investors for the therapeutic or the diagnostic, but there are oftentimes different sets of investors, as your question implies. The kind of risk profile, the timelines. Not everybody has a stomach for FDA risk or clinical trial risk, and then there are people that really know the diagnostic space well, and that's where they like to deploy capital. And there's still a number of very high margin diagnostics that are out there that are very attractive, and this is one. This will have very likely margins well in excess of 70% in terms of gross margins on the diagnostic. So it's not pharmaceutical margins, but it's a very attractive margin in the diagnostic space. And as I mentioned, we're talking about 1 million patients in the US, and the competitive technology that's basically standard of care for the diagnosis was developed in 1904. So to put that in perspective, uh, there's been nothing really that's the same things I was doing in medical school and the same things that my predecessors have been doing for over 100 years is the current standard of care. So our technology is materially disruptive in that CNS diagnostic space.
Marc Hedrick, President and CEO of Plus Therapeutics. Marc, thanks so much for your time today.
Danny, thank you. Appreciate it.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send an email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.